Newcastle. This is a working group that is actually fairly new, has only been recently established. And the key issues here is that psychosocial care provision in the NHS for people with Duchenne is very patchy. Waiting times are sometimes outrageous. You know, if patients have to wait for 2 years or longer. There are acute situations where you need to get access immediately to a psychologist if there's suicidal tendencies or severe depression, or so there's a clear unmet need to improve this. We are aware, of course, and I think this is a thread going through all the discussions, that the NHS is underfunded, and this also applies to psychosocial care. So the psychosocial care group therefore also looks at research, because in contrast to what we have heard in the amazing presentations from John Berg, for example, or the respiratory group, where we know so much about the pathophysiology, the pathology, you know, where outcome measures have been well established, where clinical trials have been performed, where interventions are in place. For psychosocial problems, we know that there is a need, but we know fairly little about them. We have patchy natural history studies. We don't have agreed outcome measures. We don't know about any biological, physical measures, for example, when it comes to imaging. So there's a lot to do in it. Therefore, it's slightly different, I think, from other working groups. So research is one aspect of this. Therefore, we also actually have very generously received additional funding because we need input from psychology and psychiatric experts. The great news for this working group is that with the funding from joining the JAC and the Duchenne Research Fund, we have been able to recruit people. There are basically 2 teams. One is in London, focusing more on adult psychosocial care and needs, and one in Newcastle, focusing more on the pediatric aspects. We have advertised actually posts nationally as well, and have also the Devon Partnership Trust involved in psychiatric care. Part of the working group are, of course, patients, healthcare professionals, and also funding representatives. It was great at the Action Duchenne meeting to actually, for the first time, have the 2 psychiatrists and the 2 psychologists that have been funded all together in person. The psychologists are funded full-time, the psychiatrists are funded 20%, and this is both for adult and pediatrics. I've listed the names here as well. There is already really active discussion. We had a meeting here yesterday as well. And it's great really to see that there is input from psychiatry and psychology with a research interest now. I think what we are missing in the UK so far, and it's actually one of my visions as well, to have an academic group led by a psychologist or psychiatrist that is driving research in psychosocial needs for patients with Duchenne muscular dystrophy. What do we plan to do? Of course, identify priority research questions, then to deliver and evaluate psychosocial interventions. In order to do this, of course, we need to know what are we going to measure. So we need to develop assessment methods. We need to educate and train experts to then do the assessments. We have heard this for many of the other working groups, whether it's cardiac or respiratory, that you need to have experts, often it's physiotherapists as well, to do the assessments. But when it comes to psychosocial assessment, we are currently lacking the expertise in the centers. I think what's really important is, of course, and we have discussed this yesterday, to also make sure that what has already been established and where patients are already assessed, to use that information to inform patients as well, inform neuromuscular experts. and to make use of research that's ongoing. And I'm just showing this slide here about the BIND project, which is led by Francesco Montoni. It's an EU-funded project focusing on the brain involvement in dystrophinopathies. I don't want to go into too much detail here. There are work packages in this project. It's overall a 5-year project. But I think what is important is that as part of the project, patients are going to be assessed by MRI as well, and by questionnaires. We use the development and well-being assessment, which is a set of questionnaires and interviews to assess psychiatric involvement in patients. The study is also listed on the clinical trial finder. So the 2 sites that are active currently in the UK are London and Newcastle. But if you have patients in your centers that would like to be involved in research, you can contact the sites as well, whether they want to participate in BIND. Outputs, ideally at the end of the project, we want to have care guidelines backed up on evidence. We need to have clarity about referral pathways. We want to have prescribing guidelines. This is something where we often see that families and patients are really experiencing a double jeopardy, where the neuromuscular expert doesn't have enough experience to prescribe drugs for depression, anxiety, or other central nervous system diseases, and the psychiatrist or the psychologist doesn't feel confident enough to deal with a disease that has heart involvement and respiratory involvement, and nothing happens. So we need to make prescribing guidelines accessible, and this is something that could then also be done through neuromuscular centers. The validated screening tools, how do we assess actually CNS involvement? How do we disseminate this? We have seen from other working groups that there are great ways to engage with learned societies as well, go to peer-reviewed journals. We also want to make a clear business case throughout the project and show in the end to trusts and the NHS that there is an unmet need that they need to also address. And so collecting this information through the project is important. And we have heard about templates that need to be established so that centers can use this in the same way as we currently use, for example, the North Star ambulatory assessment. We also want to do a survey. This will be driven by Rory, the child psychiatrist in Devon, to get a bit more information about the patient and family view on psychosocial care, but also look at other models of diseases where it is currently commissioned and standard that patients are seen by a psychologist or psychiatrist. For example, if you're diagnosed with diabetes as a child in the UK, you see a psychologist as well as part of the diagnosis, which should be the case for Duchenne as well. Also looking at aspects of course, of providing the diagnosis to the family. So therefore, we include diagnosis as an important aspect within this working group. And this is not how do you establish the diagnosis of Duchenne, but how do you actually manage the impact of the diagnosis throughout the course of the disease. And many families tell you that they will never forget the day of the diagnosis because it changed their life. And many families are also traumatized by the way a diagnosis has been given. And I mean, many of you will have heard that some patients receive diagnosis through telephones, the worst case scenario probably. But how do we also inform the patients, the boys? How do you inform a 5-year-old one about the diagnosis? And then we have heard that patients are very keen to actually get updated information when needed and wanted. So that's something that's important and part of this working group. I've mentioned the screening tools. That's something where we work with BIND together, or can work with BIND together. We have also now seen that having psychologists and psychiatrists involved we can offer student placement for clinical psychology students. And it was just by coincidence yesterday that I received already 2 inquiries from students in Newcastle who want to work with us on a Duchenne project, which is fantastic. You know, building the expertise is something we need to do because that's missing. And Ross Quinlivan is actually coordinating a workshop, I think by the end of the month, Ross, to look at prescribing and what is best practice here. Other points, I think what is important is managing expectations, of course. We do now have access to consultations through psychiatrists and psychologists, but it doesn't mean that the 4 people that we have employed through the project can cover all the needs. And it's important that patients don't, and clinicians don't expect that, oh, we have sorted this through the funding. I mean, this is temporary. This is really a working group. So we need to continue to work also with the community. And when it comes to the community, despite the fact that often experiences very poorly and you have to wait, nevertheless, in terms of long-term follow-up, engaging with community pediatricians, with CAMS teams is important. And this is where our psychiatrists and psychologists can help as well and provide advice. It's very important to also understand that some of these diagnoses require really in-person contact and assessment. This cannot just be done via a video conference call. That's the first step, really, and it's something that can then be discussed about, you know, how to proceed from there. So this was my introduction a bit to you about what we are planning to do. It's very exciting and very important that we have this new psychosocial working group in place. I'm very grateful to also Duchenne UK to coordinate this, and for the Duchenne Research Fund and Joining Jack to provide the additional funds. And I will hand over to Janet now to give a perspective a bit from her point of view.
Thank you. Hi there, my name's Janet Hoskin, and I am one of the parent representatives on the Psychosocial Working Group. And I also teach on special educational needs and disability programmes at the University of East London. So I work with sort of beginner teachers, really. So when the big questionnaire that we've heard a lot about today was first sent out in 2021, I think psychosocial care came out as like the bottom, the least well supported. And so Alex and Kathy asked me to do some focus groups with parents just to find out a bit more about what was going on and what the in more detail about what the difficulties were. So I ended up having 5 focus groups and talking to about 31 parents, 2 men and 29 parents, and 4 of the clinicians I did interviews with as well. And I just wanted to share some of the key findings from that, really. So the first thing that parents were really saying was that there's a real lack of acknowledgement about these neurobiological differences, and it is really causing a lot of concern for them at home, but also at school. Because schools aren't, always on board that some of this behaviour is not just being naughty, and that actually there is autistic. There's a big risk of autism in Duchenne muscular dystrophy, and this inflexible behaviour is really causing problems for them. And I know that Nick sees a lot of this in schools when he goes in to meet teachers. And also a lack of acknowledgement of mental health difficulties. And so, parents want this to be more acknowledged, is what they were saying, and part of the Duchenne profile, so much more talked about. It also became clear that where the mental health and the more depression and anxiety type of problems were happening was when children were sort of beginning to lose ambulation. And we already know this from research that's been done, but it was very clear that as soon as boys were being left out of things, couldn't go out with their friends, couldn't get into other people's houses, all these sorts of things. This was causing a lot of, a lot of difficulties, a lot of mental health problems. And also with parents really struggle with that. That's what parents really, really find hard, is that difference, that difference that's becoming more and more extreme as boys become more and more left out and isolated. There was a discussion about a big theme that came out was this need for a roadmap. That, you know, we know there are certain points in the journey. We know that at 12 and 13 or 10 and 12, when boys are beginning to lose ambulation, that they do need extra support and they do have these psychosocial needs. So, you know, why aren't we giving them certain support at certain recognised times? Yesterday, Rory talked about the need to have certain assessments, you know, before school and between primary and secondary school. So again, we need some kind of roadmap. Some of the parents with adults were saying, you know, my son's really struggling with his mental health. He's gone off the rails. He's, you know, doing crazy things. And actually, if it had been normalised to have these psychosocial, these meetings with people about how they felt, holistic meetings, then they would probably have had somebody to talk to and they would be much more able to cope, would have built much more resilience than actually how they're feeling now. So there is a need for this kind of ongoing discussion. Yeah, the systems Volker's already talked about really, and a lot of the clinicians were saying this about the lack of a pathway. What do we do? You know, who do we refer these people to? And if we go refer to CAMS, it can take 2 or 3 years. And even when you get to CAMS, a lot of the parents were saying, oh, we waited 2 years, we got a CAMS appointment, and then CAMS said, oh, well, he won't talk to me, so I'm going to close the case. And so, you know, what's going on there? We need some kind of, surely a toolbox of, you know, a way of intervening, of engaging young people, which, you know, you would think would be quite standard. But anyway, so those sorts of issues, yeah, and it being very inflexible. And finally, you know, people did talk about things that worked, and I think quite often, you know, I know I go on about this when I do sort of training sessions, but we do always talk about the deficit, and it's really, really important to look at all the things that families and young people are struggling with, but there are things that work as well, and we do need to unearth those and think, what are the strategies that work for schools? What are the strategies that work at home? What are these kids into? You know, oh God, he's really obsessed with, you know, Marvel movies, but actually we can use that to an advantage. We can flip the lens a bit and we can think about what can we do with these young people to give them, you know, ultimately psychosocial needs is about having a good life, isn't it? And what is it that we can do to support people having, you know, a fantastic life that they can have. These are just what came through, because I did a very small questionnaire with families, and I mean, this is quite interesting. We've got quite 23%, I think it is. Sorry, I haven't got the percentages ever by. Not a very helpful slide. So about 23% self-reported autism, no ADHD, which was interesting because when you look at the literature, there's a lot of ADHD, and whether that's to do with lack of referral pathways or whether it's to do with people not being aware of it, or maybe it's not, you know, I don't know, who knows. Autism came up high, and I think dyslexia was the second highest, but also very high, having more than one diagnosis, which was interesting, what we're dealing with. And these are just some more of the things I've probably discussed already. I don't think there's anything that I haven't mentioned, actually. Oh yeah, this was what's annoying as well. Parents mentioned and clinicians mentioned, actually, they're often in their trusts. They've got these like amazing psychology departments, people doing all these things, and for things like diabetes or for cystic fibrosis, I think you automatically get psychosocial support that, you know, is given to you from the trust, but in Duchenne you're not. And so, you know, what's going on there? Can't we, like we're talking about building a business case to actually go and say people with Duchenne, they need as much psychosocial support as these other conditions. Just very quickly, just to talk a bit about what Nick's been doing in school. So this is just to give you a picture of the sort of work he's been doing. So a lot of families that he's worked with over 2022, often you'd say it's to do with helping parents get their education, health and care plan. So again, it's still controversial. You know, you've got this complex condition that can have all these overlapping difficulties, and still schools are saying, oh, you don't need one. He's also had to, sorry to talk on your behalf, Nick, but attending tribunals, going in front of judges, you know, it gets to very serious points, and it's very stressful for parents to have to go to this point, but you have to do it to, you know, to get the support, really. And I just wanted to flag this up, and it's something that was said yesterday, and Anna talked about it, but the Special Needs Code of Practice, there are 4 categories of need. You probably know this, I don't know, but, you know, often this gets sorted out for Duchenne in their education, health and care plan. So you get the sensory and physical needs, but often we don't get stuff about communication, interaction, cognition and learning, and social and emotional and mental health difficulties. And if I think we could work at some point over the next year or so, or even sooner maybe, with clinicians about how to write letters that would acknowledge these 4 areas. These are the established risks. These are the things we know about Duchenne for cognition. We know there's a high risk of reading difficulties. I mean, there's lots published on the difficulties. That, you know, it's not controversial. You don't have to give a diagnosis of that young person, but you could flag up that it is a risk, and it would be really, really helpful for families when they're in schools getting their education health and care plans. Yeah, and then this is probably quite similar to things that you've said. So needs for conversations, families want to talk at clinic appointments. So, you know, we've talked about doing a screener, so hopefully that can be an outcome for the project. The letters I've said about, you know, just to say as well to clinicians that your letters do carry a lot of weight. So if schools and teachers have these letters from you, it can make a massive, massive difference to the provision they're getting. So don't think, oh, I'm not a neuropsychologist, so this isn't going to make any difference. It really does. They do really listen. And yeah, and just the pathways, which we've talked about. Yeah, that's it. Thank you.